Good morning, everyone. My name is Ellen Barra, and I'm a specialist with our Provider Outreach and Education Department. Today, we're going to be talking about evaluation and management, the data element of the Medicare medical decision making, and we'll be able to do questions and answers. On the phone with me today, or on the webinar with me today, is my friend and colleague, Leanne Foster. And Leanne is going to be watching the chat for any of your questions. She will also have some additional information that she will place in the chat for you. We did receive some pre-submitted questions on other aspects of medical decision making, such as the problem and the risk. We won't be addressing those during this presentation today. We will keep the presentation to data. We just completed a webinar on the problem element, and that is available on our in our YouTube channel. It should be available on our encore page on our website. You go into the training center and then scroll down to encore page, and then there's a list of the encores that we have out there. If it's not out there today, it should be out there on Monday. And then risk will be next week, I believe it is, and you can still register for that if you choose to. We also received some questions on the split shared requirements, on modifier 25, etc. We won't be discussing those here. We do have encore presentations available on our YouTube channel under the for the split shared under the E&M playlist. And then we have the modifier 25 fact sheet available on our website. And then we also have encore presentations on our YouTube channel. You can go into that, do a search for global surgery or modifier Monday, and the modifier 25 information will be there. As we stated earlier, we do want this to be a great customer experience for you. We're hoping that the information that we provide you here today is valuable for you, and you will have several opportunities to take a survey. For those of you that are listening through the encore, you also have an opportunity to take a survey that's available within the description of the video itself. And then at the end of the video, there's a end card that you can use that will take you to that description. And then that has the URL link for that survey. And we do encourage you to take the survey. We use this for reporting to CMS. We use this for reporting to our upper management. And then the specialists, such as myself, we use this to look for suggestions for ways that we can make our education better. You'll also have an opportunity to give us additional topics that you would like to see as education in the future. So you don't have this particular slide within your presentation that you downloaded from our website. We do want to let you know, though, that the Interactive Voice Response System, or IVR, is going to discontinue the eligibility function by the end of March in 2025. You do have other eligibility resources. You have the Secure Access Portal. You have direct data entry, and then you can also do a HETS, which is the HIPAA Eligibility Transaction System. This is mandated by CMS, and then we have the change request for you, the 13754, if you want to go take a look at the instructions from CMS. The next thing that we have is our disclaimer, and we provide this with all of our educational products. This information is as accurate as we can make it as of today. If you've been with Medicare for any length of time, though, you know that Medicare rules do change. The CMS instructions are the final determinant of coverage along with your documentation. We will provide you with responses to your questions based on the facts that you're giving us, but again, the Medicare rules determine that final coverage. CMS does prohibit recording of the presentation for profit-making purposes. So so we would ask then that you don't do screenshots, you don't record this. Again, we will have this available both on our website and our YouTube channel as encore presentations. So what we're going to talk about here today is really just a brief overview of the data element of the medical decision making. We'll then be able to take your questions. We have additional encore presentations concerning time. If you're choosing your level of service based on time, we have a more complete, I guess you could say, YouTube on choosing your level of service that will go into time and into medical decision making. So these are just some acronyms for you. You know, Medicare tends to be kind of an alphabet soup, so we kind of gathered these up all in one spot for you. The next thing that we have is information from the Social Security Act, Section 1862A1A. This is the first thing that you need to look at when you're looking at documentation. It's the first thing that Medicare contractors look at if we're evaluating documentation. And then the other contractors within the Medicare program who may request documentation from you. So when we're talking about medical necessity, the service has to indicate, the documentation has to indicate that the service is for the diagnosis or treatment of an illness or injury, or to improve the functioning of a malformed body member. So the American Medical Association owns the codes and the description of the procedure codes. CMS does not own those. This slide just reminds you that the definitions for those procedure codes and the instructions on how to choose your level of service changed. In 2021, it changed for office or other outpatient services. In 2023, it changed for the other categories of service. You choose your level of service again based on time or medical decision making. Now, there are two exceptions to that. Emergency department visits are only done based on medical decision making. The time for an emergency department service does not or is not what you use to choose your level of service. And then, of course, critical care time is time only. So the AMA has three different elements to choose your level of service. The first one is number and complexity of problems that were addressed, amount and complexity of data to be reviewed and analyzed, and then the risk of complications of the patient management. This would be the plan that your physicians and practitioners have put into place. When you're using medical decision making, just like any other E&M, there does have to be face-to-face service that is provided with that. So again, as I stated, today we're going to talk about the data element. Each of these categories of the data element, each of the different levels of service, have certain requirements concerning numbers and then documentation to support that. So we have those up on your screen for you. So category 1 is going to be tests and documents. So this is going to be tests that you're ordering and reviewing for your patient. It could be other medical records, other documents that you're reviewing for your patient to determine that plan of care. For the low levels, you also have category 2, which is an assessment requiring an independent historian. This moves to category 1, though, when you get into the moderate or high level of the data element. And then you have category 2, which is an assessment requiring an independent interpretation of the tests that you're looking at. And we'll talk more about how that works here in a minute. And then you have category 3, discussion of management or test interpretation. And again, we'll talk about how that works. So as you can see here on this slide, we have the two of the levels here. For the straightforward level, it does not require any data to be reviewed or analyzed. One of the questions that we received from a physician, unfortunately, said, okay, I don't meet the low category for data. Can I just order another test? Well, the answer to that would be no. You're not going to be ordering testing for the patient unless that patient needs the test and that physician needs the results of that test in order to do the plan of care. When we're looking at medical record documentation, that's part of what we would be looking at. We just completed a webinar maybe 2 weeks ago, which is available in that E&M playlist, talking about the fact that we're going to begin reviews of the procedure code 99214. And the reason why we're doing that is because of data analysis. We were actually doing another targeted probe and educate review on lipid panels. And what we found in looking at that is a lot of those lipid panels were not medically necessary for that patient. It didn't fall into the payment parameters by Medicare. Well, because those were not medically necessary, then it affected the level of service. So you only want to be ordering what your physicians and practitioners feel that they need in order to determine the plan of care for that patient. Now, as you can see on here for the low level, you have the two different categories to choose from, and you must meet the requirements for those particular categories. And you can see there that for low, you have to meet the requirements of at least one of the two categories. For category 1, you have to have a combination of two of the following, and then it lists those there for you. Category 2 is an assessment requiring an independent historian. So under the category 1, tests and documents, you can see here we have review of external notes from each unique source. And we'll talk about that in a little more detail. Review results of each unique test, and then ordering of each unique test. When we talk about ordering of a unique test, the review of that same test is part of the order. So that would only count as one when you're looking at this particular category. Under category 2, the need for the independent historian, and you can see there the word says requiring independent historian. This is needed because the patient cannot provide a complete or reliable history. This is not the same thing as a spouse or a daughter adding information during the encounter. So what you would need to show within your documentation there is why you need that additional historian to help you determine what's going on with that patient and help you determining that plan of care. We had a pre-submitted question about, can we count labs that were reviewed that were from another provider? And the answer to that is yes, when they're external notes, not your practice or your same specialty. Another question that we received is, can you count the order when you're billing for the test? For labs, yes, you can. For other services that have both a professional and a technical component, such as a chest x-ray, for an example, you can when you're billing for the technical component. If you're also billing for the professional component, then no, you would not count that as a test that had been ordered. And then another pre-submitted question, can we count as two unique sources when we're reviewing both a cardiology and a neurology note from the same hospital stay? And the answer to that would be no. It's one unique source, it's that hospital chart. So now we go up to the moderate level. And again, you can see independent historian has moved into category 1. Category 2 is now the independent interpretation of tests. And then category 3 is the discussion. For moderate, you have to have 3 from category 1, but you still only need to meet one of the 3 categories. For the high level of data, you have to meet 2 of the 3 categories. One of the areas of confusion seems to be a review of a test and ordering a test. When you're ordering that test for the patient, the review is part of that order. And again, that goes back to the medical necessity. Why did you order it if you're not going to use those results? You would not count this twice. Now, there are some different things that could be happening with that patient. For an example, you order an A1C for the patient. You count it once. The analysis of that A1C result is part of the order. Another example, however, is you see the patient in January and you order monthly INR testing for that patient. You would count it once for your January encounter, and that's for the order and the review. When you see the patient again, and you're now reviewing those additional INR testing, then you can count that once because it's a unique test. You count that once again when you have that next encounter. One of the questions that we had again has to do with independent interpretation. You can count the order as long as you're not billing for that professional component of the test. Another pre-submitted question that we had is, can we count the discussion of management with members of our group? And the answer to that is no, if they're the same specialty. Now, if your family practitioner is talking to your cardiologist concerning that patient's care, then yes, you could count that. If they're talking to another family practitioner, then no, you could not. And then that would also include any conversations with ancillary staff or a non-physician practitioner working under that physician. And another pre-submitted question, can we count the discussion with a patient case manager? And you can if they're outside of your group. And here we have the same information for the high level, but again, you have to meet 2 of those 3 categories. So let's talk then about what it means to actually analyze that data. Well, this goes back to the proof of thought for your practitioner. The practitioner is reviewing or analyzing those test results to help determine the plan for that patient. When you see the patient in June, and we're going back to the INR testing, you analyze those test results, and that helps you determine the plan for the patient, what needs to happen next for that patient. This could be keeping everything the same, it could be making adjustments, but you're reviewing those results. And Medicare makes the presumption based on the AMA instructions that you are reviewing those test results. You want to have that documentation in there. We had a pre-submitted question about, does pulling results into the into the medical note count as analyzed? Well, again, we go back to proof of thought. Where is it within the documentation that the provider is indicating that he or she reviewed those test results and is using those test results for the plan of care for that patient? When you're looking at the test results, etc., um, data from another source, what you want to look at is what are you using for this encounter today. Then we have information on tests defined, and again, this is from the AMA. Imaging, laboratory, psychometric, physiological data. A unique test is based on the procedure code with an exception. If you have a procedure code that includes other services, such as a lab panel, then this is really just one. You would not count the individual tests under a code that includes those individual tests. And then the last sentence there, you can see that the AMA does not consider a pulse oximetry as a test. So you wouldn't count that as a test ordered or reviewed. In category 2, for the moderate and high level, there is an independent interpretation. And this would really be similar to what a radiologist or a pathologist would do. You're looking at the x-ray or slide and you're providing an interpretation and a report within your documentation. You're deciding what that test shows. This is above a review where you view the test and then make your decisions. So next we have information on what is considered unique. So we talked about a unique test, but now let's talk about unique in another aspect. If you're reviewing records from the last 3 ER visits for that patient from ABC Hospital, this is one unique source. ABC Hospital is your unique source. If you're analyzing the testing from those ER visits, that's also considered a unique source. The AMA published a Q&A document on that, and I placed a link where you can see this on the AMA website on a later slide. This is not, however, a review of your previous medical records. It's not a review of other medical records from physicians within your group with the same specialty. Again, it can include if your family practitioner is reviewing notes from your cardiologist or your cardiologist is reviewing notes from your family practitioner. They have different specialties, and therefore that can count as a unique source. So one of the questions that we received is, well, what about an encounter 3 days ago, and now the patient calls back and you order a test? Well, the test is not part of an encounter, so the ordering of that test would not go to that visit 3 days ago because you didn't do it then. But when you review that test during the next encounter and your documentation shows that, you can count the review of that test during that encounter. So the next thing that we have then is external defined. So it is someone outside of your group, outside of your specialty. You'll also notice here that it says other qualified healthcare professional, facility, or healthcare organization. That goes back to the ER records, back to the hospital records, another practitioner outside of your group, a practitioner within your group, but with a different specialty. And then you can also see in the second bullet point, it could be facilities or hospitals, could also be nursing facilities, home health agencies, etc. Then we have information on category 3, which is a discussion. This is a real-time discussion between the practitioners. So this could be the cardiologist discussing an aspect of the patient care with the family practitioner. This is an interactive exchange of information. It's not leaving a note or something like that within the shared medical record. It is an interactive discussion between the two parties. So they're communicating back and forth with each other. They could be talking to each other, it could be text messaging back and forth, etc. This could be where it's obviously a discussion of the patient's care. It's gathering information to be able to make those decisions. It could also be a practitioner having a conversation with, let's say, the radiologist concerning the test results themselves. You want to document the conversation or the communication, and then you want to document why you needed that, and then how you're using that, if you are, because in some cases you may not be, but you want to document how you're using that within your plan of care. It doesn't have to be on the date of the encounter, but if it's not on the date of the encounter, then you're not going to be able to count it for that encounter. When you're reviewing that information for the next encounter, that's when you can count that information. And depending on the nature of the conversation, this could go on for several days. So you would not count it until you see the entire interactive communication and when that is actually completed. Here we have information again on that independent historian. And just as a reminder, it is where you believe the patient is not able to provide you a complete history. So you want to say why you believe they can't do that within your medical records. And then you'll notice on here it does not include translation services. Here is information on the independent interpretation of tests. A clinical lab service would not qualify for this because there isn't a professional component for that. This could be radiology, pathology, etc. And again, you would not submit a separate charge for this if you're including it in your E&M service. You can submit a separate charge for it, but it just doesn't count as part of your E&M. Now, the documentation must support that interpretation. So we're looking for a report on the interpretation of that test. So it would be similar to what the radiologist would do, although it doesn't necessarily have to be at that same level or at the same specificity as what the radiologist would do. But what we would need to see in the documentation is that it really is an interpretation as opposed to a review of that test. We had a pre-submitted question. Can we count as an independent interpretation when the hospital performed a telemetry and our physician provided the interpretation? You can if you're not billing separately for that, and there is a separate procedure code. And again, it would have to have both the professional and the technical service. Can we count the same test as both reviewed and an independent interpretation? And the answer to that would be no. You can count the order if it's all happening at the same time, but only the review or the independent interpretation. Another pre-submitted question, can the NPP document the physician's interpretation of the test? Well, they can if they're acting as a scribe. The person who's billing for this and who's counting this really should be the one documenting their interpretation of that test result. Another pre-submitted question is, can the doctor state reviewed and agreed with radiologist? And the answer to that would be no. This would be a review. In order to bill for the or include the independent interpretation, we would need to see that physician's report on the test results. Now, again, it doesn't have to be a separate document within your medical record. It can be within the encounter record, but it has to be enough that another person looking at that, reviewing that, can tell it's an interpretation as opposed to a review. So again, we go back to it's going to be very similar to a radiology report as opposed to, this is what either I'm reviewing the radiology report or I'm reviewing and here's what my plan is. Discussion of management, we've kind of talked about a little bit already. The AMA has stated specifically, it's not simply notes left within the medical record. It is an interactive exchange, where they're asking questions, the other person is responding, giving advice, suggestions, and something else. A pre-submitted question that we have or that we received is, would a quick conversation to ask if another physician will take a patient, would that count as discussion of management? And the answer to that is really no. If they're simply asking Dr. So-and-so, will you take this patient? There's really no discussion as part of that conversation as to your plan of care. Now, if there is a discussion going on and that's documented, and the end result is that you're going to refer that patient, then you could count that. Your documentation really needs to be pretty clear if that's the situation that you have. The next information that we have is just some resources for you. We have a link for the Social Security Act, that medical necessity section we talked about. We have information from the AMA. And that third bullet is where it talks about the fact you can count as two unique sources, reviewing the ER record as an example, and then also reviewing those test results that happened during that ER encounter. And then the CMS Internet Only Manual Publication 100-04, Chapter 12, that kind of contains all E&M services. And then CMS has also published an evaluation and management service guide that you can use. So we're getting ready to take questions here in just a minute. Again, we just as a reminder, we will have a way for you to take a survey here in just a second. We do encourage you to do that. We are anticipating the results on that. For those of you listening through our encore presentation, again, you also have an opportunity to take a survey. So before I ask Leanne to give us the questions we've received in the chat, we do have a pre-submitted question about how to use the data element when a service is split shared. Well, if you're using the medical decision making in order to determine your level of service, I'm sorry, let me rephrase that. If you're using your medical decision making to determine the billing practitioner, then whoever did that data, ordered the test, did the independent historian talk to them, did the independent interpretation, etc., that would go to providing the substantive portion of that medical decision making and of that service. So Leanne will go ahead and open it up for questions then.
All right, Ellen. First question is, would you count the provider's documentation that they reviewed the MAR towards data under review of external source?
Okay, Leanne, repeat that again for me. I'm sorry, I got lost.
No worries. Would you count the provider's documentation that they reviewed the MAR towards data under review of external source?
Okay, no, not unless it is a different specialty. So what I'm assuming you're talking about by using the acronym MAR is the medical record. And so if it's just a note, something along those lines, you would not count that. If it is a physician of a different specialty than the one doing the encounter today, then yes, you can count that.
All right.
Ellen, This is Hannah. So MAR may stand for Medication Administration Record, which is typically completed by med aides or nurses. Does that adjust the answer at all?
Thank you very much for that, Hannah. I appreciate that. It, the it no, yes it would. I'm sorry, let me rephrase that. So if that terminology is talking about the Medicare administration record within your medical record itself, then the answer to that would be no. That would not be evaluating a unique source. It's part of your information. Thank you, Hannah. And just as an FYI for you guys too, Hannah, who just helped us with the answer to that question, is a member of our medical review staff. And we asked her to join us here today in order to help us answer questions if we needed it. So thank you, Hannah. Next question.
Okay, next question is, since the review of CPAP data after the initial application of the device doesn't have a procedure code to support unique test, would you count that towards data in any of the categories?
If there isn't a procedure code, and you're reviewing, like a remote monitoring or something along those lines, you wouldn't be able to count it under the tests themselves. You could be able to count that as part of, um, documentation that you're reviewing, as long as you're not billing for that remote monitoring. If it is simply part of, the history that you're gathering from that patient, then no, you would not be able to count that.
All right, next question. Does the lab work ordered need to be applicable to the reason the patient is being seen on that date of service? Providers often like to perform blood work for an upcoming annual appointment, but they don't have anything to do with the reason the patient was seen on that date of service.
Okay, and that's a good question. Remember that services for that encounter have to be medically necessary. So if you're ordering a test and there's no information in there about why you're ordering that test doesn't go with whatever you're seeing the patient for, then no, we would not be able to count that because there's no reason that we can see for that. So in those situations where you're going to order a lab test, and the lipid panel is a real good example of that one. You're going to order that lipid panel now during this encounter today, and you want that patient to have that before they come back in for their annual wellness visit, for an example, in 2025. Then yes, you can count that, but you need to document the reason for the order of that encounter. Good question.
All right, next question. Sorry, just have to scroll down. When there is a spouse or loved one at the appointment to provide additional information, and the note states that the patient is a poor historian and/or has a diagnosis related to memory issues, does that satisfy the requirement for an independent historian?
Yes, it does. Because you can have both of those situations. The patient is a poor historian, and you have, your physician or practitioner knows that, or because of some dementia, possibly some mental health issues, etc., you can't trust what it is that they're telling you. And so then the spouse, the daughter, the son, whatever, other people could also provide that additional history. You're working harder, and that's really what this is all about. You're working harder in order to get that information so you can make a great plan for that patient. So the answer to that question is yes.
All right, next question is, if a physician works for X hospital medical group and the care manager works for X hospital, is this considered outside of group?
No, this would be part of your group, and therefore it would not be considered a unique source.
Next question is if you independently interpreted a previous test that was ordered and billed by a provider in your same specialty or group, would this count as an independent interp?
If it was billed by the same specialty, same group, no, you would not count that as an independent interpretation because you're billing for the actual independent interpretation of that test. If it was different specialties, your radiologist reviewed it, your family practitioner is doing an independent interpretation, then yes, you could count that as part of your E&M level.
All right, Ellen, the next question I think may be similar. Is it permissible to get credit for an independent interpretation of lab tests or a path report?
Lab tests, clinical lab services, no. Those are reviewed. The nature of the test itself does not lead itself to an independent interpretation. If it is a pathology report on a specimen, and the pathology is different than clinical labs, and you're not either the practitioner, or a member of the same group with the same specialty is not billing for that pathology, the professional component, then yes, you could do that as an independent interpretation as long as you meet the requirements for that.
All right. Next, the question is, would a statement of, I discussed the assessment and plan with Dr. X and they are in agreement with the plan be acceptable for discussion of management?
No, you need to have that interactive exchange. So you need information that shows when that occurred, what was the discussion. Um, Let me think on this one a minute. Read the question to me again, Leanne.
Absolutely. So would a statement of, I discussed the assessment and plan with Dr. X and they are in agreement with plan be acceptable for discussion of management?
Okay, I'm going to change my answer on that one. And yes, I believe that would be acceptable. Your physician and practitioner is identifying who he had that communication with, and that practitioner is identifying the information that came back from that additional practitioner. So yes, I would count this.
All right, next question. For a hospital stay, can you count review of labs and imaging of that stay separately from the rest of the hospital documentation? Or is it inclusive notes from different specialties only counting as one unique source?
Okay, when you are reviewing medical records from ABC Hospital, if you have multiple physicians within that hospital record, that is one unique source. That's ABC Hospital. The AMA has stated, however, that the test results that are part of that medical record, those are another unique source. And so you can count the review of of the test results separately from reviewing the record itself.
All right, next Next question is similar to one we already had, but I'm going to read it anyway. Is a statement such as I reviewed the above labs enough to count as proof of thought to count for counting a review of labs?
Yes.
All right. And next, if a provider is reviewing a test that they did not order and the patient has had two done, say an x-ray in October of 23, same x-ray in June of 24, is it counted as 2 points or one?
It only counts as one if they're the same procedure code. If they're different procedure codes and it doesn't fall into the exception that we talked about, like several tests within one lab panel, then yes, you can only count that as one because they're one procedure code. If you're reviewing a chest x-ray and a shoulder x-ray, for an example, from someone else, you could still count those as two because they're different procedure codes.
Okay. Next question, does signing lab results a week prior to the visit count for data reviewed?
You can, if your physician documents that they have reviewed those lab results as part of that encounter, then yes, you can count that, even though it wasn't ordered during that particular encounter. Let me kind of back up on that one just a minute. If you counted the order of those tests during a previous encounter, then no, you would not count the review. Because if you counted the order from, let's say, May, as part of your medical decision making, when you review those same tests for your encounter in August, that would not count because it's already counted for your service in May. That is difficult. I understand that. Um, but what you want to be looking for within your documentation is, when were the tests ordered? Were they ordered during an encounter? And if so, then they were more than likely counted as part of that encounter. So don't count the review again, because that's really counting the same information twice.
All right. Next, does signing lab results a week prior to the visit count for data reviewed? Oh, I just read that one. Sorry.
That's
Apologize.
okay.
It is becoming more commonplace to use secure chats between providers to speed up communications that are necessary to improve care versus waiting to have an in-person conversation. Do those secure chat conversations not count as discussion with external providers?
The only thing that the AMA has said is that you can't leave a note, like in the medical record. But if you're texting back and forth, if you're doing a chat back and forth, that counts as the communication. It doesn't have to be in person. It doesn't have to be where you're actually speaking to each other. A secure chat would work, text messaging would work, email would work. Just not a note left in the medical record without direct interactive communication with that other party.
All right. Next, for independent interpretation, is it a requirement they look at raw source and write their own opinion, example, images, etc., and not restate the results from the report of the original source, meaning the radiologist?
That's exactly right. I'm sorry, when you're doing an independent interpretation, I keep getting those two words mixed up. When you're doing an independent interpretation, you are looking at the chest x-ray. You are looking at the slide for a pathology test. You're looking at that raw data, and then your physician or practitioner is making an interpretation of that raw data. And then they're doing a report within their medical record. Or, I mean, they could be doing it separately, but they could also be doing it within the medical record. If they say, for an example, and I think we talked about this, I agree with the radiology report, I reviewed and agree, kind of whatever language they're doing, that's not an independent interpretation. That's a review. And so you would count it as a review of that test, not as an independent interpretation.
All right, next question. Our provider documents independent review of telemetry ordered by other specialties. What would need to be documented to count that as independent interpretation?
Well, for the telemetry, number one, you have to see if there's a procedure code for that. And off the top of my head, I don't know that. If there's a procedure code for the telemetry and it includes both a professional and a technical portion, then it goes back to that independent interpretation requirements, which is you have to be looking at the test and you're doing a report of your findings on that particular test.
Okay. Next, for the CPAP, can they use the uploaded usage information utilized to make adjustments to the CPAP settings as data reviewed or for data review, or is this considered as part of the compliancy of CPAP use?
Okay, well, it would be considered compliance, but let me go back to, let's go back to the slide that says, and I'm not going to move my slides, but it's slide 14 where it says test defined. These are imaging, laboratory, psychometric, or physiologic data. So if that's what your test result is showing from the CPAP, imaging, laboratory, psychometric, or physiologic data, then yes, you could count that as a test, and you could count, or you could count the review of that information under the data category.
All right, and that actually took care of the next question as well. So moving on to the next, if your hospital owns the clinics, does reviewing a hospital stay by your family physician count as a review?
If you're a part of the same health organization, then it would not be a unique source. A unique source is, somebody outside of your particular organization. So no, it would not count as a unique source.
All right. Do you consider a regular cardiologist and an interventionalist cardiologist the same group?
What you would need to look at for that is a list of our provider specialties that's available on our website. Go into the WPSGHA.com and you want to choose your category, either J5 or J8, and then Part A, or well, you want to choose Part B, and then do a search under provider specialties, and then it will tell you, and I believe that a cardiologist and an interventional cardiologist are two different specialties, but I'm going based on memory. I don't have the screen in front of me. If they're two different specialties, then you can count them as that. If they're not two different specialties, then no, you wouldn't.
Sorry, I was grabbing that link. Next
Thank you.
question. What if the patient is a child and an independent historian, the parent, is in the appointment providing a history? Does the provider still have to state the patient is a poor historian to be able to count that?
Well, now you want to think about that one because Medicare really doesn't deal with children a whole lot. There are children who are eligible for Medicare, but if you have a child, then that pretty much is going to tell us, that you need additional information from the parent. If you get up into the teen years, though, maybe not so much. And then maybe for those patients, you would want to include that additional information, why you needed the information from the parent.
All right, next question. If a cardiologist reads and gets credit for an echo and the cardiology group has an EP in their group, can the EP get credit for the review on their visit?
If they are different specialties, and again, that's what it goes back to, what the AMA has said. If they are doing a review of the cardiology report of that test, then that would be part of the review. If they're different specialties, that would be considered a unique source. Um, if they're and if they're part of the same group, you want to make sure that cardiologist did not bill for the professional interpretation of that, the professional component. But if they didn't bill for that, if it's a unique source, then yes, they can count that review.
Next is asking, does ordering a DME supply count as an order?
No. Again, you want to look at the definition of tests, which are imaging, laboratory, psychometric, or physiological data. The ordering of DME, the referral to another provider, ordering PT or OT for the patient, all of that is part of your risk category, not part of your data category. When you're looking at data, this is information your physician or practitioner is using in order to determine that plan of care. Okay, and Leanne, we have time for one more.
Okay. If I am an independent physician and have a discussion with a care manager, that counts as external provider. But if I am employed by a medical group the hospital also owns, then that discussion with a care manager does not count, even though the substance of those conversations is identical?
Correct, because your case manager in that particular situation is not going to be a unique source if they're part of your same group. If the case manager is outside of your group, then yes, you can count that. And so that's the last question that we're going to be able to take today. If there are additional questions within the chat, if we receive additional questions following this presentation, then we will respond to those, and we will include those in a document that we'll send to all attendees. So before we go, we just want to thank you very much for your attendance today. We know you guys are all busy and taking the hour out of your day to hear this information. We really appreciate that. We do encourage you to take the survey, both if you're listening to our live webinar and if you are listening to our encore presentation. We are really interested in your feedback. So this concludes our presentation today. You can now disconnect. Have a great day.